Every precise, forceful downward strike of a modern mechanical chest compression device is engineered to maximize kinetic energy. Modern advanced cardiovascular life support operates as a highly calibrated, data-driven science. We measure compression depth to the exact millimeter and strictly enforce rates of 100 to 120 beats per minute. Yet right beside all of that mechanical perfection, the primary method for delivering oxygen to the patient relies on a manual bag valve mask. Delivering air this way is an entirely open-loop procedure. There is no measurement, no data, and no calibration. It relies entirely on human estimation. In practice, that estimation translates into the rapid, uncalibrated force of a human hand crushing a resuscitation bag. During a cardiac arrest, extreme cognitive load and adrenaline degrade fine motor control. Under that stress, highly trained providers will inevitably hyperventilate the patient. This failure takes two distinct forms: squeezing the bag too frequently, driving up the respiratory rate, or squeezing it too hard, forcing massive, excessive tidal volumes into the airway. To genuinely optimize cardiac output, clinical practice must abandon blind tactile ventilation. We require a shift to closed-loop, data-driven airflow measurement, because forcing unmeasured air into a patient actively works against the life-saving potential of every single chest compression being performed. To understand exactly how hyperventilation destroys cardiac output, look at this cross-section of the human thorax. It is a tightly sealed environment containing the lungs, the central heart pump, and the inferior vena cava, the main vein feeding blood up into the heart. Normal human breathing operates on negative pressure. As the diaphragm drops, it creates a vacuum within the chest. That vacuum actually pulls venous blood upward through the inferior vena cava and into the right atrium. A back valve mask reverses this physics. It utilizes positive pressure ventilation, forcefully packing air into the chest and drastically spiking the internal pressure gradient. When a panicked provider delivers an unmeasured, massive breath, the lungs aggressively overexpand, filling the available space in the thoracic cavity. The immediate result of that pressure spike is mechanical compression. The delicate, low-pressure walls of the inferior vena cava are violently pinched shut by the swollen lungs. This interrupts preload, the volume of blood entering the heart prior to contraction. A collapsed vein immediately reduces preload to zero. If preload drops to zero, the heart is completely empty. A mechanical compressor can execute a flawless, high-energy downward strike, but if it compresses an empty pump, it yields zero cardiac output. Zero blood reaches the brain. The physiological math is clear. Squeezing a ventilation bag too hard directly starves the brain of blood during CPR. The standard ACLS target for ventilation is exactly 500 to 600 milliliters per breath. Yet elite EMS and critical care teams consistently miss this window. The failure stems from the tactile illusion, the pervasive belief that providers can accurately gauge how much air they are delivering simply by the physical resistance they feel in the back. That tactile feedback is medically unreliable because of dynamic lung compliance, the physical stretchability of the patient's respiratory system. During a code, compliance changes violently. Ribs fracture during compressions, airway resistance fluctuates, and internal anatomy shifts. The stiffness of the bag constantly changes meaning. This scatterplot illustrates the stark divide between perception and reality. The y-axis tracks delivered tidal volume, with a narrow green band sitting exactly at the 500 to 600 milliliter target zone. When we look at clinical data, estimated volumes routinely spike into the dangerous 800 milliliter range, or drop ineffectively below 300. The target zone is almost entirely abandoned. The providers delivering these breaths are completely unaware of the deviations. They feel the same resistance in their hands, even as the output swings wildly. Human perception simply lacks the computational speed to adjust for dynamic lung compliance under extreme stress. Objective external data is required. To solve the pressure paradox, tactile estimation must be entirely replaced by real-time flow measurement. This requires building a closed-loop system. Devices like the EOLife sensor module sit directly in the ventilation circuit, snapping into a straight, inline sequence between the bag and the patient's airway. Positioned here, the slow sensor actively intercepts the column of air before it enters the body, sampling the exact mass passing through the valve. The onboard processor rapidly calculates the exact milliliter volume of the incoming breath, along with precise breath-to-breath timing intervals. This crisp digital interface converts that complex physics into immediate, actionable cues. A high-contrast bar graph tracks volume in real time, hitting the target exactly at 500 milliliters, while a clear counter tracks breaths per minute. This instant visual feedback overrides muscle memory. The provider physically stops squeezing the exact millisecond the optimal volume is reached, before overinflation can occur. The engineering loop is closed. A chaotic, blind squeeze is successfully transformed into a precise, targeted dosage of air. Optimal resuscitation demands two aligned elements: the kinetic precision of mechanical compressions and the data-driven precision of guided ventilation. When ventilation volume and rate are precisely measured, human lungs inflate symmetrically to an optimal, safe maximum capacity. Precisely controlled tidal volumes ensure that intrathoracic pressure remains strictly within biological limits. Keeping that pressure low guarantees the delicate walls of the inferior vena cava remain wide open. An open venous system guarantees continuous preload, ensuring the right atrium is constantly refilled with blood from the body. And when the central heart is full, every single mechanical chest compression can deliver its maximum kinetic energy, pushing maximum blood flow outward to the vital organs. Utilizing real-time feedback systems to guide ventilation achieves the definitive mechanical requirement for protecting cardiac output and maximizing human survival.